Welcome back to the deep dive. Today, we're really digging into something fundamental, something that might just change how you think about your own body.
Absolutely. We're challenging the map, you could say.
Exactly.
Hmm.
If you crack open a standard anatomy textbook, you see muscles laid out very neatly, right? Like separate little engines, each with its own start point, its origin, and end point, its insertion.
Discrete actuators. That's the classic terminology. Pulling on levers, basically.
Right. But here's the thing, that map, it's looking increasingly, well, incomplete.
Massively incomplete based on recent work.
Yeah, detailed studies on cadavers, worked
Hmm.
by Wilk and colleagues, Vanderwall before them, they're showing something quite different.
They're showing that these muscles, these actuators, aren't isolated at all.
No, they're all stitched together, directly linked by fibrous connective tissue. We're talking about a continuous fabric.
And it's not just minor connections. It's extensive enough that it forces us to rethink how forces actually travel through the body.
So, if the body isn't just a collection of separate parts, what is it? We need a new way to understand movement, stability, even injury.
Precisely. So that's our mission for this deep dive. Really getting to grips with myofascial chains and how force gets transmitted. We need to understand continuity, figure out what's actually mechanically significant, and see what it means clinically.
Yeah.
Okay, let's unpack this. It really is a paradigm shift. We're moving away from seeing the body as segmented bits and pieces.
Like a machine made of separate parts.
Exactly, and moving towards a much more functional, holistic view. Some people like the term tensegrity structure.
Tensegrity. Explain that a bit.
Okay, so imagine a structure where rigid parts, like our bones, aren't stacked directly on top of each other for support. Instead, they're suspended, floating almost, within a continuous network of tension elements.
Which would be the fascial system in the body.
That's the idea. The whole thing works as one unit. If you pull on one part of this tension network, the whole structure responds, it adjusts. Stress gets distributed everywhere.
Okay, I can picture that. And the tension elements in the body are, well, there's a whole range of structures. Ligaments, fasciae themselves, these broad sheets called aponeuroses, and of course tendons, they all act as bridges between muscles, connecting everything up, connecting everything. Take a really clear example from the research. The link between your hamstrings, that big sacrotuberous ligament in your pelvis, and the erector spinae muscles in your lower back. Okay, hamstrings to low back. How does that work?
Well, that sacrotuberous ligament is like a thick rope. When you contract your hamstrings, say bending forward, the tension doesn't just stop at your hip bone.
Right.
It pulls on that ligament, and the ligament, in turn, pulls on the fascia connected to your erector spinae muscles. So your hamstring tension is directly helping to stabilize your lumbar spine.
Wow, okay, so bending over isn't just a hip and back thing. The whole back of the leg is involved in controlling the spine.
It's all connected, and you see it further down, too. The gastrocnemius, your main calf muscle, has significant fibrous connections, a fascial bridge directly to the hamstrings above it.
So pushing off the ground with your calf.
Some of that force gets transmitted mechanically, straight up the chain, assisting the hamstrings and hip. It's not isolated to the ankle joint.
That idea of force flowing seamlessly. Calf to hamstring, hamstring to spine. That's the key concept here. And all these different bridges, ligaments, fascia, tendons, what makes them so good at transmitting that force? It boils down to one core property. They all have considerable tensile strength.
They're strong when you pull on them.
Well, definitely.
They resist being pulled apart. And that strength comes mainly from one thing. Collagen-type fibers. Tons of them. Collagen, right.
Yeah.
The body's structural protein, like high-strength wiring.
That's a great analogy, and what's really fascinating is how similar these tissues look under a microscope. It kind of challenges why we categorize them so separately.
So.
Well, researchers looked at the knee, comparing the fascia lata, that dense sheath around the thigh, with the tendons nearby.
Okay.
And they found they share very similar biomechanical properties, similar biochemistry, similar histology, how the tissues are structured. Butler and Derwin's work showed this. So if you just look at the material itself and how it behaves, fascia and tendons aren't that different. Much more alike than traditional anatomy would suggest. And this is the bedrock for proposing this, well, revolutionary idea. Group all these soft collagenous tissues together under one name. Yeah, under one umbrella term. The fascial tissues, or the fascial system, as from and colleagues suggested this, the fascial system. What are the implications of thinking about it that way?
It implies that the distinctions we make, tendon injury, ligament sprain, fascial strain, might be, functionally speaking, a bit artificial. Treating the body effectively might mean treating this whole system, not just one isolated part.
That's a huge shift, treating the system.
It is, and it's why this idea of myofascial chains is so compelling. If all this tissue is connected, then muscles and the stretch-resistant tissue create these systemic lines of pull.
Lines that can transmit force across joints to faraway parts of the body.
Potentially, yes. But, and this is crucial, anatomists don't just draw lines randomly. To verify a chain, it has to meet strict criteria. It needs to be mechanically logical.
Okay, what are the criteria?
The first big one is continuity of longitudinal axes. The structures have to line up along their length. Think of it like laying fiber optic cable.
You want the straightest path for the signal.
Exactly. Minimize signal loss, or in this case, force loss. Any big disruption or sharp turn, and the tension gets dispersed.
Makes sense. And the second criterion?
Common fiber orientation. The collagen fibers in adjacent structures need to run in roughly the same direction.
So the wires are aligned to pass the tension along smoothly.
Precisely. Which brings us back to the fiber architecture itself. In tendons and ligaments, it's mostly parallel fibers, perfectly aligned for pull in one direction.
Right, very strong along that line.
But then you look at investing fasciae, those sheaths around muscle groups. They often have a more complex crisscross lattice-like arrangement.
You'd think that would dissipate force, maybe? Make it less efficient for straight-line pull?
That's what you might assume. But biomechanical studies show something fascinating. Even with that woven structure, they exhibit a markedly higher stiffness along the longitudinal axis. Eng and colleagues demonstrated this.
Higher stiffness along the line of pull. How does that work?
Think of a Chinese finger trap. It's woven, right?
Yeah.
But when you pull on the ends, the longitudinal axis, it becomes incredibly rigid in that direction.
Ah, okay. I get it. So even woven fascia can transmit force effectively along its length.
Exactly. It validates their role as key parts of these functional chains.
Okay, that finger trap analogy really helps. But now we hit a really critical point, maybe the most important distinction in this whole deep dive.
Which is?
The difference between just proving anatomical continuity, which seems widespread,
Yes, the body is basically all connected.
and proving mechanical significance. Just because muscle A is physically linked to muscle B via some fascia, does that connection actually matter?
Right. How much force actually gets across? That's the key question for clinical relevance.
Is it 5% of the force or 50%? Because that changes everything. One is a curiosity, the other is a fundamental mechanism we need to account for.
Absolutely. Significance is the hurdle.
And we also need to remember, this continuity isn't just in series like links in a chain. It's everywhere. Muscles lying side by side, synergists, even antagonists, they're linked in parallel too. Yusoi's work highlights this.
Myofascial continuity is global. It's the fabric itself, not just the seams.
But even with that global continuity, the cadaver studies, where they can carefully measure forces, they do show real, measurable interactions between muscles connected in series. Krause's review points this out.
Yeah, despite individual variations, the serial connection is functionally there. You can measure it.
So anatomical connection first, then the hunt for mechanical significance.
Yeah.
Where in the body is this significance most obvious, most critical?
Well, the low back regions is a major focus. It seems to be a real hub for this kind of force transmission.
Makes sense. It connects the upper and lower body.
And the lumbar fascia, that thick sheet of connective tissue in the low back, is described again and again as the mechanical hub of the posterior diagonal myofascial chain.
The diagonal one.
Yes, it acts like a crossroads. It receives tension from the latissimus dorsi, the big back muscle on one side,
Okay.
and the gluteus maximus, the big buttock muscle on the opposite side. Vleeming and Barker's research nailed this down.
Ah, so that's the X pattern across the back.
Yeah.
When you walk or throw, your shoulder on one side is linked to the opposite hip.
Exactly. It's a powerful tension sling that stabilizes the core diagonally.
And what about the straight up and down chain, the posterior longitudinal one?
Just as clear. We mentioned the hamstrings pulling on the lumbar fascia via the sacrotuberous ligament. That's classic Vleeming work too. Your hamstring tightness directly tunes the tension in your low back.
Okay.
And further down that same chain, you've got solid evidence for interactions between the hamstrings and the gastrocnemius, and then between the gastrocnemius and the plantar aponeuroses in the foot.
So from foot to low back, it's one continuous mechanical line when you're pushing off, standing, jumping.
The evidence suggests it functions as a unit sharing the load. But This leads to a really tricky, unresolved question.
Which is?
The parallel question. Look at figure 1.6.5 in the source. Does the force transmitted along these chains, in series, actually exceed the force transmitted between structures lying side by side, in parallel?
Ah, right, because we know muscles tug on their neighbors, too.
Exactly. There are strong parallel interactions, especially shown in the lower leg. Wilkes' group found this. Yeaman and colleagues showed that if you change the length of the gastrocnemius, even with the ankle fix, you get significant strains in the soleus and fibular muscles right next to it.
So they're pulling on each other sideways, significantly.
Significantly. So is the dominant force transfer happening end-to-end along the chain, or side-to-side between parallel muscles, or both?
If the parallel transfer is stronger, it wouldn't kill the chain idea, but it might mean the chain is just one piece of a more complex puzzle.
Precisely. It forces us to consider multiple lines of tension simultaneously. It complicates the picture, but makes it more accurate.
Okay, so it seems the body uses both end-to-end pulling and side-by-side squeezing. Fascinating. Based on those strict criteria, though, longitudinal continuity, shared fiber orientation, which chains have been systematically verified. Which ones form the current evidence-based map? Based on that rigorous approach, Wilkes' 2016 review identifies 3 core lines as systematically verified: the posterior longitudinal chain, PLC, the posterior diagonal chain, PDC, and the anterior diagonal chain, ADC.
Okay.
Okay, the PLC, PDC, and ADC. Let's break those down. Start with the PLC, the posterior longitudinal.
Right, this is the big one running up the entire back of the body. Think of it as our primary anti-gravity system in the sagittal plane front to back.
Components. Ground up. Okay, starting at the foot. Plantar aponeuroses, the tissue in the arch.
Yep. Then Achilles tendon, gastrocnemius, the calf.
Got it.
The hamstring muscle group, the sacrotuberous ligament we
The
mentioned.
pelvic rope.
And finally, connecting into the lumbar fascia and the erector spinae muscles, one continuous cable.
And its main job.
Resisting gravity, basically. Controlling and supporting posture, whether you're standing tall or bending over. And it's crucial for initiating and stabilizing vertical movements. Think jumping, landing, the push-off and running. It handles that vertical force transfer.
But you mentioned earlier this chain isn't static over time.
Right, that's a key point. The strong connection, almost a fusion, between the plantar aponeuroses and the Achilles tendon tends to decrease or even disappear with age. Snow pointed this out way back in '95, and Stecco's group confirmed it more recently.
So that link at the bottom weakens. What does that mean functionally?
It likely means the efficiency of the whole chain degrades. Transferring force from the ground straight up the spine might become less effective, potentially contributing to gait changes or instability in older adults.
Interesting. Okay, what about the diagonal chains? They handle rotation and connect opposite sides. Let's do the posterior diagonal chain, the PDC.
Okay, the PDC. This is the power sling for cross-body movements. Think athletic actions.
The conants.
It often starts laterally, with the vastus lateralis on the outer thigh linking into the gluteus maximus.
Okay, outer thigh to buttock.
Then across that crucial hub, the lumbar fascia, crossing the spine to the opposite side latissimus dorsi.
Lat muscle on the other side.
And then the line continues into the brachial fascia of that opposite arm.
So outer thigh hip on one side connects across the back to the opposite shoulder arm.
Precisely. Its function is connecting the body sides, allowing interaction between arms and legs, and initiating or controlling those cross-sided movements. Throwing a ball, swinging a bat or golf club. That powerful rotation comes from the PDC.
But you mentioned a nuance about the arm connection.
Yeah, the source material points out that the brachial fascia in the arm doesn't stick as tightly to some underlying muscles like the biceps compared to how strongly, say, the lat connects to the trunk fascia. Meaning, while the chain is anatomically present all the way to the arm, the actual force transfer might weaken as it goes down the arm. The pull might be strongest across the trunk and shoulder and less effective further out. Okay, a potential weak link, or at least a less efficient link, in the arm segment. Now, the third verified one, the anterior diagonal chain, the ADC. Front of the body, mirrors the PDC's function, but on the anterior side, handles counter-rotation and flexion across the midline.
Components for the ADC.
Starts with the adductor longus inner thigh, groin area.
Okay.
Connects up into the rectus abdominis, the six-pack muscles.
Abs.
Then across to the pectoralis major, the chest muscle, and again, out to the brachial fascia of the arm.
So inner thigh connects to abs, connects to chest, connects to arm fascia.
Right.
And its function is very similar to the PDC, connecting body sides, coordinating limbs, controlling cross-body movements. Think kicking a soccer ball across your body or a twisting crunch. And does it share that same potential limitation in the arm?
It seems so. The sources again highlight that the brachial fascia connection might mean reduced force transfer further down the arm, for instance, to the triceps, compared to the very strong link via the pec major to the shoulder and trunk.
So for both diagonal chains, the trunk-to-shoulder connection seems mechanically very robust for rotation, but the passive fascial pull into the distal arm might be less significant.
That seems to be the implication from the current understanding of the fascial connections there. Local muscle action in the arm becomes more critical. Okay, those are the three verified lines: PLC, PDC, ADC. But you mentioned other chains have been proposed, more complex ones.
Oh, yes.
There are various body maps out there, some quite old, showing elaborate lines, spiral chains wrapping around the torso. Myers Anatomy Trains is probably the most well-known modern example, building on earlier ideas.
But the systematic research hasn't fully verified all of those.
Correct. Based on the strict criteria, two commonly discussed chains are currently only partially supported by evidence. They contain links that are still unverified anatomically or biomechanically. These are the lateral longitudinal chain and the spiral chain.
The frontier, then. Let's look at the lateral longitudinal chain first.
Yeah.
What's its proposed role?
It's generally seen as the body's side-to-side stabilizer. Think controlling movement in the frontal plane, resisting side bending, or preventing the knee from collapsing inwards, valgus, or bowing outwards, varus, the lateral pillar.
Okay, and its components run up the side of the body.
Extensively, starting down low with the fibularis muscles and crural fascia in the lower leg, connecting up into the IT band, gluteus maximus, and TFL at the hip.
Big hip stabilizers?
Then continuing up via the abdominal obliques, the intercostal muscles between the ribs, and reaching all the way up the neck through muscles like the splenius capitis and sternocleidomastoid. It's meant to provide lateral stability for the whole system.
A complex line. And the spiral chain. That sounds even more intricate.
It is. It attempts to integrate multiple planes, especially rotation, wrapping around the body almost like a double helix. But critically, when we list the components, many links are flagged in the source as unverified continuities.
So connections that are still theoretical.
Exactly, not yet backed by solid biomechanical proof. The proposed path is, well, intricate. It might start with the erector spinae, link via the sacrotuberous ligament to the biceps femoris hamstring,
Okay.
down through the fibularis longus, across the front of the ankle via tibialis anterior, back up the side via the IT band TFL, then through the core obliques, across the back shoulder via serratus anterior and the rhomboids, ending up at the splenius muscles in the neck.
Wow. That's a journey, like wringing out the body. It really is. And its assumed function fits that image. Producing and controlling rotational forces like spinal torsion in sports, and also helping the lateral chain with frontal plane stability. But given all those unverified links, it remains perhaps the most challenging chain to confirm experimentally. It highlights just how much we're still mapping out, and this mapping isn't static, right? You mentioned factors that change these connections.
Absolutely. The fascial system adapts. We talked about age affecting the PLC connection at the ankle. That's a big one. A structural change with age has definite biomechanical consequences.
Are there other factors?
Well, things like physical activity level and maybe gender are often suggested as influencing how well force is transmitted myofascially. You know, the idea that a lifelong athlete might have a tighter, more efficient system.
Makes intuitive sense.
It does, but the hard data isn't really there yet. We lack systematic studies looking at how training history or gender differences actually change the mechanical properties of these chains. It's an area wide open for research.
Okay, now, this is where it gets really interesting for me. Moving from diagrams and cadavers to the living, breathing, moving body. In vivo studies. Does manipulating one part of a chain actually affect a distant part? Can we measure these remote effects?
This is where the clinical relevance really starts to hit home. And yes, the initial evidence for these non-local effects is pretty compelling.
Give me an example. Okay, get this. Studies have shown that stretching the gastrocnemius and hamstrings, core parts of that posterior longitudinal chain, calf and back of thigh,
actually leads to a measurable increase in range of motion in the neck. Cervical ROM.
Wait, stretching your calf makes your neck more flexible. Seriously?
Seriously. Wilkes Group published on this. It's a direct functional link demonstrated in living people, seemingly along that PLC pathway.
That's wild. Any others? Another striking one. Self-massage of the plantar aponeuroses, just working on the arch of your foot, like rolling on a ball.
Exactly. That's been shown to increase hamstring flexibility. Hamstring extensibility goes up.
Treating the foot improves the hamstring. Again, following the PLC.
Precisely. Grieve and Wilk have studies on this too. It's not just anecdotes, it's measured data suggesting the chain is transmitting something tension, or maybe allowing relaxation along its length.
Okay, those functional results, more
Mhm.
flexibility, more range of motion, that's what people notice. But hang on, we have to be careful, right? Just because B happens after A doesn't mean A caused B through purely mechanical stretching.
Exactly. That's the critical scientific thinking we need. These in vivo findings are super important, but without, say, simultaneous imaging showing the fascia stretching or maybe neural monitoring, we can't definitively say passive myofascial force transmission is the only reason for the remote effect.
What else could be going on?
Well, one major possibility is cortical adaptations, changes in the brain.
Meaning,
If you stretch intensely or massage a sensitive area, your central nervous system might simply recalibrate its threat level. It might increase your tolerance to stretch or pressure.
so the brain just lets you go further, even if the tissue isn't physically longer.
Potentially, yes. Your perceived endpoint of the stretch shifts. That would immediately show up as increased range of motion systemically without any actual change in tissue length. Distinguishing that from a mechanical effect is tricky.
Okay, so neurological adaptation is one possibility. Any others?
Another one is neurovascular transfer. Remember, nerves and blood vessels run through fascial sheaths and cross multiple joints, too.
Right.
It's possible that stretching or massage is actually mobilizing these nerve or vessel bundles, freeing them up if they were a bit restricted or stuck. And that improvement in neurovascular mobility could be what allows for increased movement range elsewhere, rather than the fascia itself stretching. Ellis discussed this possibility.
So it could be the nerves gliding better, not the fascia stretching more.
It's another plausible mechanism that needs to be considered. Likely, it's a combination of mechanical, neurological, and perhaps neurovascular factors all playing a role.
It's complex. We're trying to untangle the pure physics from the body's perception and control systems. But even with those caveats, the chain concept seems really helpful when looking at actual injuries or pain problems, right?
Mhm.
Finding issues far away from the main symptom.
Yes, this is where the model shines in clinical observation. Remote dysfunctions often show up alongside local pain, suggesting the whole system is involved.
Like what?
Take low back and sacroiliac joint pain. Patients often show hyperactivity, like over-tensing, of the latissimus dorsi on one side and the gluteus maximus on the opposite side.
The main muscles of the posterior diagonal chain.
Exactly. Mooney and Kim's work showed this. That pattern strongly suggests the whole diagonal sling is involved, maybe compensating, maybe overloaded. It points towards needing a systemic approach, not just focusing on the painful spot in the back.
Okay, that makes sense for the diagonal chain. What about the PLC in pain syndromes?
Well, it's consistently linked to chronic low back pain. While the exact relationship is debated, people with chronic lumbar pain frequently have tighter, stiffer hamstrings. Marshall and others have documented this.
Pain in the back correlates with stiffness in the leg along the chain.
It appears so. And it goes all the way down. Look at plantar fasciitis, that painful stiffness in the arch of the foot.
Yeah.
Studies show that people with plantar fasciitis often also have increased stiffness in their hamstrings and their gastrocnemius. Leibovitz and Bolivar found this.
So the stiff foot comes with a stiff calf and stiff hamstrings. The whole PLC seems tight.
It provides pretty strong clinical support for the idea that the body stiffens along that entire posterior line when one part is chronically stressed.
Well,
But we have to end with a final, crucial clinical limitation.
okay, what's the catch?
While these studies show strong correlations, pain here relates to stiffness there, we still lack robust evidence on the success of treatments specifically based on these chains.
Meaning we don't have enough high-quality trials showing that, say, treating the hamstrings is definitively better for plantar fasciitis than just treating the foot.
Exactly. We need more randomized controlled trials, RCTs, to prove that these chain-based interventions lead to superior outcomes compared to standard local treatments. Until we have that level 1 evidence, the myofascial chain model is a powerful lens for understanding and diagnosis, but its superiority as a primary treatment strategy still needs more validation.
Okay, that's a really important dose of reality. So this whole deep dive, it feels like it fundamentally reshapes our view. The old idea of muscles as independent little engines just doesn't hold up anymore.
It really requires thorough revision. Fascial tissue is clearly a mechanical force transmitter, linking everything together. So the big takeaway for you listening is, don't just focus on the site of pain. Whether you're a therapist, an athlete, or just curious about how you move, you have to think systemically. See the body as this integrated network of tension.
Absolutely. And we're left with some big unknowns driving the research forward. We still need to figure out how much of those remote effects are purely mechanical versus neurological adaptation. Crucial question.
And does the force transfer along the chains actually exceed the parallel transfer between adjacent muscles? Which pathway dominates? Answering that will really shape future diagnostics and treatment.
Couldn't agree more. The systemic view is definitely the future. And maybe one final thought for you to chew on, circling back to that fascial system idea.
Okay.
If fasciolata, tendons, ligaments, if they all share similar properties, if they're all part of this continuous adaptable system transmitting force globally, why do we still treat them so separately?
Good question. Historically, we carved them up for surgical specialties, for diagnostic labels. But if functionally they're all interconnected parts of one organ, maybe we need to rethink that. Is separating a tendon issue from a fascial issue always the most helpful approach? Or should we be thinking about how treating a ligament might instantly change the load on a distant muscle within the same chain? Are our current distinctions holding us back from treating the system more effectively?
Wow. That's a phenomenal question to end on. It really challenges the foundations.
Yeah.
The future isn't in the segments, it's in understanding the connections. Thank you for joining us for this deep dive into the revised map of the human body.